hematology. Today we are going to be discussing body fluids that are often analyzed in the laboratory. Uh, the three types of fluids specifically that we're going to discuss are cerebral spinal fluid, synovial fluid, and our group of serous fluids, which include pleural, peritoneal, and pericardial. You may sometimes hear peritoneal fluid referred to as ascites fluid. Let's start out with cerebral spinal fluid, CSF. So before we talk about exactly what spinal fluid is, let's talk about first some of the anatomy of our brain and spinal column. Essentially, our brain and spinal column are covered by three membranes. The outer membrane is called the dura mater. The arachnoid mater is a filamentous kind of spidery-like tissue between the inner and outer layers, and then the innermost delicate layer is called the pia mater. We are going to find our cerebral spinal fluid between our second and third layer, so between the arachnoid mater and the pia mater. Essentially what CSF is an ultrafiltrate of plasma produced by brain ventricle lining cells called the choroid plexus and ependymal cells. And it circulates again in that subarachnoid space between layers 2 and 3. Cerebral spinal fluid has a really important job maintaining protection for our central nervous system, specifically our brain and spinal cord. But it also maintains a stable chemical nutrient medium. So we want to make sure that all of the cells associated with our brain and spinal fluid are getting the nutrients and chemical elements that are needed for proper metabolism. And along with that metabolism comes waste, cellular waste. So the CSF also helps remove the waste from that brain metabolism. The total volume of CSF in adults is about 90 to 150 milliliters with a constant turnover rate of about 150 milliliters per hour. So that means every hour we have a whole new supply of CSF. Neonates, because they are smaller, have a lesser volume than adults with a total volume of 10 to 60 milliliters. Okay, so why do we analyze CSF in hematology? Well, there are a number of reasons. Typically, we obtain it for diagnostic purposes as well as therapeutic. So with regard to our therapeutic purposes, that might be to administer drugs, or if a person has too much CSF, we might relieve that excess pressure there. The method of collection for CSF is performed by a lumbar puncture. You might have heard it called a spinal tap in the past, but the technical term for it is lumbar puncture. Typically, when CSF is collected, they will collect 4 tubes. The first tube is going to go for chemistry analysis. Second tube is going to go for micro in case they want to do any type of culture. And then hematology, our tube is number 3. And that's where we're going to look at the cell count and the differential. With the fourth tube, those are going to be for specialty testing or miscellaneous testing, maybe some send-out testing if they want to do perhaps a meningitis panel or cytology. So that's going to be for those type of tests. The fluid is going to be analyzed based on a few different components. We're going to look at color, clarity, our red blood cell count, white blood cell count, and of course our differential. Those are going to be specific to what we do in hematology. So normal CSF should look pretty much like water. It should be colorless, clear, and for the most part pretty acellular. There should be no red blood cells and only a very few white blood cells, so 0 to 5 white blood cells per microliter is usually the normal cell count that we would see in a healthy individual. And the most of those are going to be lymphocytes, so about 70% lymphocytes, maybe 30% macrophages or monocytes. Typically, we don't see neutrophils circulating in the CSF unless there's inflammation or infection. Neonates, because children, as we know, are still developing their adaptive immune system. So those neonates can have up to 30 white blood cells per microliter. And again, children between the ages of 5 and 13 may have up to 10 white blood cells per microliter. And again, the majority of those are going to be lymphocytes. So the first two components that we really evaluate in CSF are the color and clarity. When we see an abnormally colored CSF, we may refer to that as a xanthochromic CSF. This is where the supernatant might be pink, orange, or yellow, and that could be due to either hemolysis and or bilirubin. A lot of times we'll see newborns with jaundice that have a very yellow CSF because that bilirubin easily crosses the blood-brain barrier and begins to accumulate in the cerebral spinal fluid. We may also see bloody CSF, and this could be for a couple of different reasons. The traumatic tap is a term we use when the process of lumbar puncture causes some bleeding. And then patients may have something called a subarachnoid hemorrhage where they actually have a brain bleed and that blood from the brain bleed will trickle down into the CSF. So how do we know if we have a traumatic tap or a subarachnoid hemorrhage if we have bloody CSF? Typically, a traumatic tap has significantly more blood in the first tube, and then as we collect tubes 2, 3, and 4, it'll dilute out. The supernatant, when we spin that tube down, is usually colorless and looks more like a normal cerebral spinal fluid should, because all of those cellular components are pulled down into a pellet at the bottom of that tube. However, with a subarachnoid hemorrhage, we're going to see an even distribution of blood throughout all of the tubes. And when we spin that down, typically that supernatant is xanthochromic. It may be yellow, orange, or pink again. Typically we see more of a pink color with that subarachnoid hemorrhage. It really just depends on how long ago it has happened. Now, in terms of clarity, we might see something called turbidity. So again, a normal CSF is perfectly clear, very much like water would be. However, when we see a turbid CSF, that could indicate an increase of white blood cells. It could indicate microorganisms and or excessive protein. Those are all associated with a variety of conditions which we're going to talk about. In this next slide that I'm going to show you, I have an example of the difference between a normal CSF, a subarachnoid hemorrhage, a traumatic tap, and xanthochromic CSF, so you can kind of see a visual of what we'd be looking at. All right, so this first picture on the top left-hand corner is what a normal CSF should look like. It's clear, it is colorless, there's no turbidity there. The second to the right on the top is what we would expect to see in a patient who has suffered a subarachnoid hemorrhage. Each one of those tubes is equally bloody, and if we were to spin that down, we might see either pink or yellow supernatant, very much like the bottom left-hand picture where we see that xanthochromic CSF. You can see that it has a yellow color to it. You might also hear a xanthochromic CSF referred to as xanthochromia when reporting out your analysis. To the right on the bottom, this is kind of representative of what a traumatic tap would look like. So that first tube that is collected is going to be very bloody because you'll have some blood accumulation that occurs during the actual lumbar puncture. And then the second and third one, as you can see, they gradually dissipate in terms of the amount of blood that's present. So there are several ways in which we can count the cells that are present in CSF, but let's first talk about our manual cell counting. And we do this with an instrument called a hemocytometer. Essentially, a hemocytometer is a modified slide with collection chambers, and on each side of that modified slide are microscopic grids. These grids are divided into 9 large cells or squares, and then some of those squares are divided into smaller squares. And if you take a look at this picture up in the left-hand corner, this is what a hemocytometer grid looks like. Those W's in each of the four corners represent what we would consider to be one whole square. And then you'll see the other 5 squares are divided into smaller grids. If specimen is grossly bloody or very turbid, dilutions can be performed, or you have the option of counting fewer squares. We just have to take that into consideration when doing a final calculation, and we'll talk about that calculation here in a moment. I do want to point out that each one of these 9 squares present in the grid on the hemocytometer is a total volume of 0.1. That means that if we count all 9 sides, we're counting a total volume of 0.9. And again, we're going to take into consideration the volume, which is always going to be 0.1 for each square, and then the number of squares that we count. Now, as I mentioned before, both sides of these collection chambers on the hemocytometer have a grid, and we are going to want to count both sides separately. And then we will average the number of red cells and the number of white cells. The important thing to take into consideration is that when we do both of those counts, each count should agree within 20% of one another, or if you have a very low count of less than 50, your counts should agree within 5 cells. So for example, if you have 25 red cells and you get 20 cells on the second count, that would be an acceptable count. But if you have 25 cells on your first count and 60 red cells on your second count, that would not be within 20% or less than 50 cells. So we really want to make sure that we're having an accurate count so that we can put out valid results on these patients. Now, if you do come across that issue, one of the things that is often a contributing factor to that is not allowing your cells to settle before starting your count. So oftentimes a common mistake that people will make is they will go ahead and put their sample on the chamber and cover it with their slide or their cover slip, and then go straight away to counting. And what happens is sometimes those cells will settle in the second side, but the first side there's still some Brownian movement, so cells are still kind of settling. I always let my hemocytometer sit for about 5 minutes prior to beginning my analysis once I've put my sample on, and that allows the cells to settle, and you have a much higher success rate with regard to making sure that your cells agree on each side by 20%. All right, so now we have counted both of our sides to the hemocytometer. They match with 20% or less, and we have averaged our red cells and we've averaged our white cells. Now we're just going to plug it into a calculation. It's a very simple calculation. We're going to take our average cells counted. If there was a dilution performed, we will multiply that number of cells by the dilution factor. And then we are going to divide it by the number of squares we've counted times the volume of each square. Now remember, the volume on each of those large squares on the hemocytometer is 0.1 microliters. So for example, if you counted all 9 of the large squares, you will take 9 times 0.1. And that will be your denominator. So here's a quick example of what a sample might look like when we plug it into the calculation. So let's say we had a really bloody sample and we had to use a dilution factor of 20 for the red count. On the first side, we counted 405 of the large squares. And on the second side, we counted 380 in 5 large squares. So we only counted 5 squares because it was a very cellular sample. They do agree within 20% of one another, and then when we average it, we get a white blood cell count of 390 red blood cells. That should say red blood cell count. I'm sorry, there's a typo there, so that needs to be fixed, but we're talking about red cells, not white cells, just to be clear. The total of red blood cells per microliter is going to be our average, which is 390 red cells, times our dilution factor, which is 20. and we're going to divide that by the 5 squares that we counted times their volume, which is 0.1. That is going to give us a value of 15,600 red blood cells per microliter. Now that we've discussed the method of manual cell count on CSF with that hemocytometer, we're going to talk about a couple of automated CSF count options that we have here at St. Luke's specifically, but a lot of other facilities also use these methodologies. Our main method is called the GlowSight. It requires only 60 microliters of CSF, so this is really ideal when we have a neonate CSF because the volume that they can retrieve is very minimal. So we have fluorescent tagged indicators for both red cells and white cells, and we put it into a reader after we have added that fluorescent tag to our sample, and it will give us a count based on the fluorescent appearance of the red cells or the white cells. It's actually a very simple methodology and it's very accurate. I really like using the GlowSight, and hopefully at some point we'll be able to go out and take a look at it. You will have the opportunity to use the GlowSight when you get into your clinical rotations on the bench. The second type of automated methodology that we use is our UF1000. So this is our UA microscopic analyzer, automated microscopic analyzer. It does require a higher volume of CSF, so I think about 800 microliters, 8 to 900 microliters, just because the aspiration volume is higher. And if we have a very grossly bloody sample, we can actually utilize our Sysmex, which is our regular CBC analyzer. So all of those methods are acceptable depending on your volume, your cellularity, and kind of all of those things taken into consideration. You could use the GlowSight for any one of those. However, if you were to have a high white or red cell count, serial dilutions may be required. So that's why a lot of people prefer the Sysmex if we have a very grossly bloody sample. Once we've completed our cell count, we now want to do our white blood cell differential, just like we would with a CBC, to determine the population of cells that are present, because depending upon the population of cells that are present, that may give us an indicator if there are any underlying disease states or infections. So white blood cell differential slides are prepared utilizing a cytospin, and then we stain them with the right stain, the same type of stain that we use for our peripheral blood smears and our CBCs. The good thing about the cytospin is ultimately it is a little funnel that, when centrifuged, will concentrate all of the cellular material into a small little button and press it up against the slide so that we can have a very concentrated area, especially in low cell counts is really helpful to get a better view of what's going on. So in normal spinal fluids, again, there's usually a mix of those lymphocytes and monocytes, or maybe you could call them macrophages. The ratio is usually 70% lymphs to about 30% monocytes. If we have a high number of lymphs, we may be looking at a viral meningitis. Remember back to our white blood cell unit that lymphocytes are highly associated with viral infections. If we are seeing a high number of neutrophils, we may be looking at a bacterial meningitis. Now, neutrophils are not, in high numbers, are not a normal finding in healthy CSF. So the minute you start seeing a lot of bacteria or a lot of neutrophils in your oh my goodness, in your CSF, that's going to be a red flag. And then our monos, macrophages, are considered one category in body fluids. That term is interchangeable, so you may call them monos or macrophages. Either one is acceptable. Um, but of course, our macrophages are responsible for kind of tidying up, keeping things clean, and just circulating to make sure everything's in good condition. Sometimes when our macrophages find things that shouldn't be in CSF, we can find inclusions in them. So we give them special names based on their inclusions. For example, macrophages that have phagocytized red blood cells are called erythrophages. And we typically see this in the early stages following a subarachnoid hemorrhage. So if you think about normal CSF, there's that blood-brain barrier. So red blood cells are not a normal finding in CSF. So if, for example, patient has a subarachnoid hemorrhage, blood is going to infiltrate the CSF and those macrophages are going to try to clean up the mess. So we are going to see whole red blood cells as inclusions in some of these erythrophages. Now, as time goes on and those macrophages are doing their cleanup duty and they are starting to break down those red blood cells that they've consumed, they then become something that we call a siderophage because red blood cells, remember, in our hemoglobin, we have a high amount of iron. We are going to start to see inclusions that are kind of dark blue, purple, or black, and those are essentially residual iron granules or hemosiderin from that red blood cell breakdown. We may also see hematoidin or hematin crystals, which are yellow crystals, and those are a component of bilirubin. These are formed from further hemoglobin breakdown, and typically we see this in later stages following a subarachnoid hemorrhage. So the type of cells we're seeing, the phase in which the breakdown of the red cells within the erythrophage as they transition to siderophage, then we can kind of see how long ago did this subarachnoid hemorrhage happen. Is this a new bleed? Is this something that happened a few days ago and has stopped? And now we're seeing the byproduct of that red cell breakdown within those macrophages who've taken on the duty of cleaning up. So here are some of the examples. In this left-hand picture, you can see a macrophage that has consumed whole red blood cells. This would be considered an erythrophage. It is happening very early on after the subarachnoid hemorrhage has occurred. So you can see for the most part, these red blood cells are not broken down at all. They've been newly consumed. The second picture is where we are looking at it in its siderophage form. So you do see a few red blood cells present within the macrophage, but now we're seeing these black or purple inclusions, and this is a residual effect of red blood cells that it have already been broken down. So these are remnants of iron granules that were once a part of those red blood cells. And then in the right picture, siderophage with hematin crystal. These little orange crystals are going to be components of bilirubin. And you can see this one's kind of on a lower power, so it's zoomed out, but you can still see those purple granules within. So it's got iron in it and these little bilirubin crystals or hematin crystals. And this would, of course, happen several days after that subarachnoid hemorrhage. The macrophages are hard at work, and we're having some residual components from that red blood cell breakdown. There are a few other types of cells that we may see in CSF that are less commonly seen. This picture here at the top are those, we may see ependymal or choroid plexus cells. And remember, if you remember, those are the ventricle lining cells of the brain that produce the CSF. They essentially provide that they ultrafiltrate that plasma, and then it becomes CSF. Now, because of their morphology, they are easily confused with malignant cells. My advice to you is if you are ever evaluating a CSF and you see some cells that you are not sure, but they do look abnormal, when in doubt, send it to pathology. We always err on the side of caution for the health and safety of our patients. And so until you become, more experienced in what you're seeing, Don't be afraid to seek another opinion. We may also see lymphoblasts in neonates, and this is a completely normal finding for them to some degree. Now, if we're seeing a proliferation of them, or we're seeing numbers much higher than what would be expected in a neonate, we may pause and seek evaluation for that. But when babies are born, they are entering a new environment. Their adaptive immunity is pretty much um, starting from scratch. They have higher lymphocytes for that reason, but the bone marrow is also adjusting to a new environment. So now the baby is becoming completely dependent on its own resources. And because of that increased need for lymphocytes, we may see some immature lymphoblasts in circulation, both in peripheral blood, but also in the CSF. In patients with ALL or AML, so those acute leukemias that we spoke about and learned about in our white blood cell unit, we may see malignant cells in the CSF. We might also see lymphoma cells, and people with brain tumors may also have some leukemic cells or some malignant cells, not leukemic cells for brain tumors, but malignant cells. Cells of chronic leukemias are not usually seen in CSF, so this is strictly for lymphomas and those acute leukemias, and then maybe a brain tumor. So if we see lymphoblasts in an adult's CSF or even a child's CSF who's not a neonate, this would be a cause for alarm, and we would immediately send this to pathology for further evaluation, especially whether or not the patient has a history of leukemia or lymphoma. We definitely want to get this evaluated by pathology. This could indicate a more advanced stage of disease, and treatment is imperative for these patients. If the vertebrae is nicked during the lumbar puncture, so say, there's a needle going in and it accidentally disrupts the bone matrix of the vertebrae, the bone marrow that's present there is going to kind of leak out. And so we might see immature cells, specifically nucleated red blood cells, and maybe even some other immature cells. And that's just more or less a contamination from that leakage of the bone marrow when the vertebrae was nicked. All right, synovial fluid is kind of a category all on its own. It is typically the fluid that we find in the joints. Synovial fluid is also an ultrafiltrate of plasma, but we have an added component of hyaluronic acid. This hyaluronic acid causes the fluid to be thick, viscous, and that helps lubricate moving joints to reduce friction. And it also provides nutrients to the cartilage because cartilage, for the most part, is pretty acellular. It's not vascular. It doesn't have a lot of blood flow to it. So this is another way of getting nutrients to those areas. The method of, or the process of aspirating synovial fluid is called arthrocentesis. And we might perform an arthrocentesis for a number of reasons. We might do it for relief of symptoms. So a patient may have excessive synovial fluid due to a variety of reasons. I don't know if you've ever heard the term water on the knee. Really, that's essentially just a buildup of excessive synovial fluid, and then there's probably some inflammation there as well. So they may go in, remove some of that synovial fluid to relieve the symptoms that the patient's having. We might do a arthrocentesis for diagnostic purposes. Maybe a patient is having joint pain and um, they want to know if there's an infection or if there's inflammation. Maybe the patient has arthritis. We want to go and look at and see what's happening there. And sometimes we remove a little bit of synovial fluid and replace it with certain therapeutic drugs. So all of those would be indications for arthrocentesis to be performed. Um, Now, because depending on the viscosity or if there's any disease state present or if there's a presence of blood, we should put synovial fluid in liquid EDTA or sodium heparin tubes prior to analysis. This keeps them from clotting if there's a lot of blood. It also keeps them more fluid and keeps their viscosity um, in a state that's more normal of what it should be. And it doesn't allow for any type of fibrin formation, etc. Sometimes we'll get a synovial fluid brought down to us in a syringe, a capped syringe, and it is just a solid mass, and it's really difficult to perform any analysis on solid samples because we need it to be able to aspirate with our um, automated instrument. We really want to avoid powder anticoagulated tubes though because of the formation of crystals, and that would interfere if we need to do a crystal analysis on synovial fluid. So normal synovial fluid is typically clear or pale yellow. Sometimes we call that straw colored, and it contains no fibrin. The normal white blood cell count for a normal synovial fluid is 0 to 200 microliters. And the cell populations that we would expect to find are about 65% mononuclear, so monocytes, and then typically fewer than 25% neutrophils and fewer than 15% lymphocytes. So that's kind of a picture of what normal synovial fluid should look like. All right, so it would be great if all of the synovial samples we got were normal, but physicians don't typically perform arthrocentesis on non-symptomatic patients. So the majority of our analysis of synovial fluid are going to have findings that would be indicative of a joint disorder of sorts. So we kind of break our joint disorders into a variety of classifications. The first type of joint disorder is non-inflammatory. Typically, the findings are clear fluid, yellow, has a normal viscosity, and we're going to have a white blood cell count that is less than 1,000 white blood cells per microliter. And we're going to have a fairly low percentage of less than 30% polys. Our glucose is going to be similar to glucose that we would find in circulating peripheral blood. Now remember, when we're doing synovial fluid analysis or really any body fluid analysis, a lot of times there are chemistry tests and microbiology tests that are associated with that as well. So I'm mostly going to talk about the hematology testing and analysis that we do, but it is important to take note of any chemistry or microbiology testing that might be associated with each one of these classifications of joint disorders. The second classification of joint disorders is our inflammatory classification, and we break this down into subcategories. The first subcategory is going to be of immunologic origin, and the second type is in crystal-induced origin. So let's first talk about immunologic origin. Typically, we will find cloudy fluid. It will be yellow in color and have a poor viscosity. Usually it's a little bit thick. And that's simply because we often see autoantibodies there, and it causes like that increased protein level there is going to cause it to be thicker. Our white blood cell count is going to be more elevated than you would see prior or previous types of disorders. So we'd be looking at a white blood cell count of 2,000 to about 75,000 cells per microliter. And we will also have the findings of greater than 50% neutrophils. We may also have a low glucose level in this regard, simply because if you think about the cell population that's present, all of those white blood cells that are present are going to have metabolic processes occurring, and they will be utilizing the glucose that's around them as part of their energy. So it will decrease the blood glucose in that surrounding fluid. And again, we may see possible autoantibodies. This is a situation where maybe someone who has rheumatoid arthritis, they would have an immunologic inflammatory joint disorder. With regard to our crystal-induced origin, which is our second subcategory of inflammatory disorders, we will see a fluid that's cloudy or milky in appearance and has very poor viscosity. And what we're going to find with regard to our white blood cell count is it's going to be even more elevated than before. This time we're going to see less than 70% neutrophils. And again, because of that high white blood cell count, we're going to have a low glucose, and this time we will be able to see crystals that are present. Now, as you become more experienced and you have, become um, more trained in your eye, I guess you could say, when you have a crystal-induced joint disorder, a lot of times when you have the fluid, you can just pick it up, and when you rock it back and forth in that EDTA tube, it almost shimmers. So a lot of times there's a good indication that you may see crystals before you even look at it under the scope. Sometimes that's not the case though. So it's always important not to make assumptions, but it's kind of an interesting finding um, just to see that kind of shimmer in the sample. The third type of joint disorder uh, is more associated with infection, and this is the septic joint disorder. The fluid in this case is going to be cloudy. You're going to have a greenish yellow color, and there will be a variable viscosity. It may be thinner than usual, it may be thicker than usual, and our white blood cell count again is going to be elevated with 50 to 100,000 microliters. This time we're going to see greater than 75% neutrophils because remember, back to our white blood cell unit, neutrophils are associated with that bacterial infection, so they are our first defenders. Because again, that white blood cell count is so elevated, we are going to have a low glucose. And in addition to our hematology testing, this time we're going to send some samples to our microbiology department for gram staining cultures. And both of those will come back positive for microorganisms, which would be an indicator of infection. And then the last type of joint disorder are hemorrhagic disorders. These essentially are where we have bleeding into the joint. So most of the time that fluid that's aspirated is cloudy. It's red because of that bloodiness and has a low viscosity. When you get a hemorrhagic joint sample or synovial fluid sample, it's in a purple top and you move it back and forth. It looks very much like whole blood. And sometimes it's really difficult to tell the difference. Our white blood cells and our neutrophils are going to be similar to peripheral blood, and that's because of all of that hemorrhaging into the joint. A large proportion of that fluid is peripheral blood. The blood glucose is also going to be similar to what you would find in peripheral blood. Now that we've talked about our cell counts and our differentials, let's talk a little bit about our crystal analysis. So if you remember back to the previous slide, we talked about one of the inflammatory classifications of joint disorders was a crystal-induced origin. So a lot of times physicians will request crystal analysis to be performed. Now the way that we perform crystal analysis, we use a wet mount slide. So we'll put a drop of synovial fluid onto our slide and put a cover slip over it. Then we have a very special compensator that we put onto our microscope, and it causes kind of a purplish red background to appear. It also polarizes the light and then will cause our crystals to appear yellow or blue. And this really depends on the species of crystals that we're looking at and their orientation to the compensator against that kind of magenta background. Now, the two most common types of crystals that we see in synovial fluid, first is monosodium urate. These are uric acid crystals that can cause gout. I'm not sure if you've ever heard of that, but it's an incredibly painful joint disorder where you have an accumulation of these monosodium urate crystals. The second type that we may find are calcium pyrophosphate crystals, and we call these pseudo-gout. So they mimic some of the symptoms, signs and symptoms of gout, but then when we look and do evaluation of those crystals, we find that there are different species of crystal than gout. So let's go back to monosodium urate. The morphology of these monosodium urate crystals are going to be kind of needle-like with pointed ends. We might find them intracellularly, or extracellularly specific to the white blood cells present. And each one of these crystals kind of behaves a little differently. So for monosodium urate, they exhibit a strong negative birefringent, and that just means that the colors that we see when they're parallel or horizontal or perpendicular to the axis of that compensator are going to vary. So monosodium urate crystals are going to appear yellow when they are parallel to the axis of the red compensator. Now, don't worry, I'm going to show you a demonstration and some pictures on the next slide so you can kind of get a visual of what I'm talking about when I say parallel or perpendicular to the axis. And then when they are perpendicular, they will appear blue. The opposite is true for calcium pyrophosphate crystals. Now, aside from having a positive birefringence, which is the opposite of that negative birefringence that we see in monosodium urate, the morphology is also a little different. They're going to be kind of small plate-like crystals. They're a little chunkier, I guess you could say. They may also be intracellular or extracellular. But this positive birefringence that we find in calcium pyrophosphate crystals basically means that the crystals are blue when they are parallel to the axis and yellow when they are perpendicular. So it's going to be the opposite of what we find in monosodium urate. We do see a couple of other types of crystals less commonly. These could be cholesterol crystals, which are essentially like flat plates that have a notched corner. They kind of look like the state of Utah. And then corticosteroids. That could be a patient who's been receiving corticosteroid treatment. Sometimes they do form crystals as well. All right, here is kind of a visual of what our compensator orientations would look like. So the two on the left are going to be monosodium urate representations, and then the two on the right will be calcium pyrophosphate. So if you note, we have a north-south axis and an east-west axis. When the little handle is swung all the way to the left, that is going to represent a north-south axis. And when we find crystals that are parallel or running north and south, they should appear yellow in the case of monosodium urate crystals. If, however, we were to swing that handle to the right, and now we're running in an east-west axis, that same crystal that was parallel to the axis before is now perpendicular to the axis and now appears blue, whereas the one that is running now east and west is parallel to the axis and is yellow. So those are going to be characteristics of that negative birefringence that we see in monosodium urate crystals. And the opposite is true for those calcium pyrophosphate crystals. When we have a north-south axis and our crystals are parallel to the north-south axis, they will appear blue, and when they are perpendicular, they will appear yellow, and then vice versa. Okay, so this is another representation of what we might see in monosodium urate. Maybe it will make it a little more clear. So if you look at the picture labeled A, the little arrows are just pointing to the crystal prior to polarization. In picture B, you can see that the axis is running, well, it's kind of running east-west, and that crystal is perpendicular. So it is blue. And then when you have the crystal running the same direction as the axis, so parallel to the axis, it is yellow. So that's what we would typically see in a monosodium urate. You may not find a crystal that is running directly north and south or east or west. So any the way that we can swing the little handle on the compensator, we can align it to be parallel to any crystal going in a direction as long as it is parallel. So there is room for you to, like, for example, this one's not, picture C, for example, is it's not fully to the left to be completely north-south. This one's running kind of northeast and southeast, but that's okay. We want to just find that parallel orientation to the crystal. So it isn't a strict northeast, south, north, south, east, west. It's really, we're looking for parallel versus perpendicular. And again, here we have an axis that's going to be running kind of north, east, or I guess northwest, which is yellow. So that's where our axis is. And then the one perpendicular to that is blue. That one's more of an east-west. But you can see how they both appear when they're oriented differently. Those are both monosodium urate crystals. You can also note that they have kind of a long, thin needle-like structure, which is typically different from what we would see in calcium pyrophosphate crystals. Now, it is possible for a patient to have both monosodium urate crystals and calcium pyrophosphate crystals. So let's take a look at the next slide and see what we were looking for with regard to the second species of crystals. Okay, so this bottom picture, this middle and bottom picture, these are going to be representative of what we would see in those calcium pyrophosphate crystals. Note they're not long and skinny and needle-like the way the monosodium urate crystals were, but rather chunkier. The diagram at the top of this picture to the left is monosodium urate representation, and then to the right is that calcium pyrophosphate, and you can see that they run opposite. So here's the axis, kind of going like northeast here, and so we would have a parallel crystal that is yellow on the monosodium urate, and then the one that would be running parallel for the calcium pyrophosphate is blue. So they're really just opposite responses to the axis. All right. Moving on from synovial fluid, let's talk about our last category of body fluids. These are our serous fluids. Our serous fluids kind of come from different areas in the body. Think of your thorax and your abdomen, the trunk of your body. These serous fluids are going to be associated with different cavities of the abdomen and thorax. And when we have an accumulation of fluid where it's not supposed to be, we call this an effusion. So essentially an effusion is an abnormal accumulation of fluid within a body cavity and are classified as either a transudate or an exudate. So this is kind of an important point to note. The effusion or the abnormal accumulation is not, it's not a normal finding, but sometimes the accumulation is associated with a disease state, but it's a more benign condition, and other times it's associated with a more serious condition. And depending upon the cause of the abnormal accumulation or the effusion of fluid within the body cavity, we classify it into two categories as transudate versus exudate. So let's first talk about transudates. When we have an effusion that is considered to be a transudate, we find a yellow, clear, low total protein, low specific gravity, low LDH, and low white blood cell count of less than 1,000 white cells per microliter. These are usually more benign, and they are often associated with fluid balance disruption. And we see this in people maybe like who have cirrhosis of the liver or CHF, so chronic heart failure, or congestive heart failure, maybe some kidney disorders, where something is interrupting the normal distribution of fluid within the body. It is not typically something that's caused by malignancy or infection, whereas an exudate would fall under that class. So exudates are typically cloudy and variable in color. They usually have a high total protein, a high specific gravity, a high LDH and an elevated white blood cell count of 1,000 white blood cells or greater. And this is often more serious and associated with infection or malignancies. So before we dig any deeper into our serous fluids, let's first talk about the type of serous fluids that we have. Each one of these serous fluids are essentially named for the area in which they are normally found. And remember, effusions are an abnormal accumulation of normal fluids. So fluids that should be there but now are accumulating abnormally. So our pleural fluid is the first serous fluid. This is a normal fluid that surrounds the lungs within the chest cavity. And we obtain a sample of pleural fluid by performing a thoracentesis. Pleural effusions are most often caused by lung or breast cancer. So if we see an effusion of pleural fluid, that might be an exudate. Not always, but sometimes. So we may find malignant cells there. Peritoneal fluid, also known as ascites fluid, is normally found in the abdominal cavity, or the peritoneal cavity as it's sometimes called. And we obtain a sample of peritoneal fluid by performing a paracentesis. Causes here might include congestive heart failure, liver cirrhosis, kidney disease, could be infection, trauma, and malignancy. So there are kind of a wide array of causes, and those can be transudates or exudates. Any one of these could be transudates or exudates. Some of them are more commonly associated with exudates versus transudate, being a transudate, but um, any one of these serous fluids could fall under those categories, really depending on the cause of that accumulation. Pericardial fluid is the fluid that surrounds the heart in that pericardial space between the pericardium and the heart muscle. It is obtained by performing a pericardiocentesis. Pericardiocentesis. Sorry about that. I had to get my tongue under control. So what can happen with an accumulation of peritoneal or pericardial fluid is it could cause a condition called chronic tamponade. And that's when fluid accumulates around the heart and inhibits normal heart contraction. This can be caused by infection, trauma, and malignancy. So again, it could be a transudate or a exudate, just depends on the cause. Most of the time, pericardial fluid doesn't have an abnormal accumulation or an effusion without, something kind of more significant than an abnormal fluid distribution. Now that we've talked about the types of serous fluids that we may evaluate or analyze, let's talk about some of the cells that are commonly seen. So the first type of cells that we might see in serous fluids that we won't see in CSF or synovial fluid are these mesothelial cells. And these mesothelial cells form the lining of pleural, peritoneal, and pericardial cavities. So they're essentially the lining cells. They differ in some ways from other cells. They often have a large amount of cytoplasm, and they may resemble quote unquote fried eggs. Now, you might hear this over and over again, especially when you get to your microbiology rotation. Fried eggs and ground glass, for whatever reason, is utilized to describe a variety of cells and organisms, but they do look a little bit like fried eggs, to be honest, blue fried eggs. Instead of green eggs and ham, we have blue eggs and ham. We might see inflammation that's occurring with a specific condition. And when inflammation occurs, these mesothelial cells can become what we call reactive. And when they become reactive, meaning they're reacting to inflammation. They may transform and become multinucleated. They might form clusters, and they may exhibit phagocytic properties. So oftentimes they can be confused with malignant cells. But we're going to take a look at some mesothelial cells so that you can differentiate between a mesothelial cell and maybe a clump of malignant cells. We'll take a look at some pictures here in just a minute. The second type of cells that we commonly see in serous fluid are neutrophils. However, we typically find a predominance of neutrophils in conditions that are associated with acute bacterial infections. So again, our neutrophils are going to be first defenders against bacterial infection. They're also associated with inflammation, but in the case of a very high neutrophil count, we're going to be suspecting a bacterial infection there. The third type of cell are going to be our lymphocytes, our good old lymphocytes. They have a predominance, which in some cases, specifically like in a pleural fluid, might indicate tuberculosis. It could indicate lymphocytic leukemia. It could indicate lymphoma, a viral infection, or a chronic bacterial infection. So if you remember back to our white blood cell unit, neutrophils are our first defenders, but our lymphocytes will come in and try to um, help with the immunity against an infection when it goes on for a long period of time. Eosinophils are also found in serous fluid. These are highly associated, again, remember back to our white blood cell unit, these are highly associated with parasitic infections and allergic reactions. So a lot of times we will see eosinophils just appear, and a lot of times it's due to, it, I see it, I think I see it a lot in eosinophilic pneumonias, which can be triggered due to asthma, to allergic reactions, but it could also be a parasitic infection. I don't always know the patient's history right off, but it's kind of an interesting finding. You don't really expect to see eosinophils circulating around in body fluids, but they are there. We are going to see monocytes slash macrophages. We don't really, again, distinguish them in body fluids, but these typically indicate a chronic infection when found in higher numbers. It's not mentioned here, but we may see basophils as well. It's not often that we see basophils, but again, remember those are associated with hypersensitivity disorders and allergies as well. So occasionally we do see basophils. It's not a common finding, but if you did see one, it wouldn't be, it wouldn't be abnormal to see one. However, what might be abnormal are malignant cells. Malignant cells usually come from the tumor associated with whatever corresponding body cavity where the serous fluid is found, but it can also be found in um, metastatic conditions. I cannot speak today, I'm so sorry. Distinguishing features include large size, variation in cell shape. We're going to see these three-dimensional ball-like clusters. Sometimes we just call them cancer cell or like cancer balls. Abnormal mitosis is going to be apparent in some cases, irregular or bizarre shapes, and molding that makes it really difficult to see individual cell borders. So what you'll note is you'll see this kind of ball of darkly colored cells or abnormally colored cells maybe, and you'll be able to see the nucleus of each of the cells, but you won't be able to see where one cell starts and the other begins. They just kind of merge into this cohesive malignant ball. And we'll take a look at some pictures here on the next slide. So here are some pictures of some additional findings. If we look here on the top left-hand corner, what we're seeing are a bunch of neutrophils, a whole lot of neutrophils, and here are some fungal elements. It looks like some yeast here, which would not be a normal finding in any of our body fluids. That could be indicative of a big problem for the patient. Next, in the slide or the picture just below that, we have some neutrophils with ingested bacteria. Now, in hematology, we don't report out bacteria because we use a Wright stain and not a Gram stain. We can see the bacteria, but we can't classify it or um, tell the doctor whether it's gram positive or gram negative. That would be something that our microbiology department would do when they do the gram stain and their culture. So most of these body fluids are sent to microbiology and chemistry as well. When we are looking at the top right-hand picture, this would be representative of a clump of malignant cells. So again, very poorly defined cellular borders. We can see all of those individual nuclei, but we can't really tell where one cell starts and the other ends. It also forms this kind of cohesive ball that has a three-dimensional form, so it looks almost like you could just pick it up right up off the slide, and the coloration is very abnormal. So this is very, very typical of what you would see in a clump of malignant cells. Again, sometimes you'll hear people call it cell balls or um, malignant balls, but this is, again, a clump of malignant cells. And then just below that are our mesothelial cells. And as much as I dislike the term fried egg because I feel it's overused and can be confusing for students, these actually do kind of look like purple or blue fried eggs. So we have that frayed, lacy edge, this nice, smooth cytoplasm, and there's abundance of that, and then these really pretty round nuclei. So the important thing, I wish we had a picture here. I should have put a picture up here that compares it to the size of other cells. They are typically much larger. However, in body fluids, although we can identify our cells because they have many of the same characteristics that they do in peripheral blood, sometimes the fluid matrix around them allows a little bit more expansion. They're not crowded with red cells, it's not quite as cellular. And so a lot of times you'll see normal white cells a little bit more spread out. So they look like they're stretching their arms a bit. And we will look at some pictures in which that's more apparent when we get to our cell atlas and our body fluid slides. But that wraps it up for our body fluid PowerPoint. Make sure you're looking at your um, online atlas, your atlas book, just to get a little bit more experience identifying specific cell types. Um, be familiar with normal ranges for all of the cells, all of the body fluids that we've talked about today. Um, when you get to your synovial fluid, make sure you familiarize yourself with how that compensator works and what type of crystals you may see. We're also going to need to know the collection procedure names that are associated with each of our fluids. And let's see what else. Oh, we're also going to want to know the disease states or the classifications, for example, like in our joint conditions. So disease states associated with various cell counts and the various causes of some of those disease states. So take a look at those. If you have any questions, feel free to reach out to me. And we will now be moving on to our UA section.